Good afternoon, everybody, and welcome to this webinar today, supported by the Royal College of Surgeons in Edinburgh and the RSA, who we thank for the opportunity to present this. My name is Mark Bignell. I'm one of the consultant surgeons at the Oxford University Hospital, specialising in emergency and colorectal surgery. And it's my pleasure to present John Taylor, who is going to talk to us today about the principles of resuscitation and damage control in abdominal emergencies. As always, for those of you who are familiar with the format, we will have a Q&A session running whilst the presentation is going on. I will answer questions as we go, but if there are any questions that are popular, please vote them up and we'll discuss them at the end. So it just leaves me now to remind you that next Tuesday we've got a session on head injury at the same time, but on Tuesday. But now let's proceed and let John take over with his talk. Over to you, John.
Okay, thanks. Thanks, Mark. So this talk's just kind of an extension of the one we did last week. This is more about the damage control, resuscitation and surgery in abdominal emergencies. Predominantly, we're talking about trauma today, but again, the principles are equally applicable to things like fecal peritonitis and other abdominal catastrophes, really. Everything's applicable, but predominantly this is for traumatic injuries. So damage control surgery and damage control per se comes from the US Navy from the Second World War, when ships got damaged in battle. And basically it was the process by which they kept ships afloat. They basically did the bare minimum to allow the ship to continue its mission or to get back to port. And that's kind of what we're doing within damage control resuscitation, damage control surgery. We are literally doing the bare minimum to keep the patient alive and then allow us to proceed on to the next stages as we'll go through. Now, damage control surgery per se was first described really in the mid-1970s in the context of liver trauma, where they looked at the process of liver packing, which we went through last week, versus definitive liver surgery in context of trauma, and they found there were massive differences in mortality between just packing the liver and trying to do something fancy. And then this took a bit of time to get traction, and then basically in the early 90s, and then a paper by Rotundo in the Journal of Trauma kind of crystallized the concepts of damage control surgery per se. It is a broader approach, okay? So damage control resuscitation consists of three broad areas. First of all, there's permissive hypertension. We allow our patients to be hypotensive, okay? Again, that will limit the bleeding until we can get control. We then have hemostatic resuscitation, which is stop the bleeding and replace blood with blood. Now, this actually is a relatively new concept, which sounds counterintuitive. In my early days as a trainee, I still remember, squeezing in bags and bags of saline, and we wondered why our patients became edematous, had multi-organ failure, and died. Who knew? Then obviously there's the damage control surgery, which actually only forms a small part of this damage control resuscitation concept. Now, a lot of this has been driven by developments in military surgery. Often many advances recently have transferred into civilian practice. Now, just to give you an overview, if you look at the mortality from pretty much any major conflict before the first Gulf War, well, up to and including the first Gulf War, if an injured soldier reached a forward aid station or reached medical care, they still had a 24–25% mortality. Okay, you had a 1 in 4 chance of dying, even if you managed to reach medical care. And then, with the application of damage control principles, again coming in from the early 90s, in Iraq and Afghanistan, in the second Iraq conflict and in the Afghanistan campaign, the percentage of the servicemen, and these are US figures, the percentage of servicemen who died and dropped, it more than halved. okay? And this is just the application of very basic principles of, damage control resuscitation. So the three areas of permissive hypotension, chemostatic resuscitation, and damage control surgery. So these all came together and saved a lot of lives. Now this is then transferred into civilian practice. Now this is new, right? One of the things with surgery of trauma, it was Hippocrates himself that first said, if you want to learn how to, deal with wounds, join an army. And, this was in the ancient Greek times. And over the years, military surgery has developed in response to conflict, and then the conflicts ended, and then we've forgotten everything. Just to illustrate this, I've got something here. This is, I don't know if it's coming up back in front there, but this is an edition of the War Surgery Supplement from the British Journal of Surgery, published in 1947. And on page 457, there is a description of liver packing. Okay? So they were packing livers in the Second World War. It took until 1974, 73 for this to get into the civilian literature. Okay? Again, it just shows you that there's a lot learned in conflict that we've forgotten, and now we're just getting to a stage now where we've kind of got over that collective amnesia. So what we're doing is we're trying to address what's known as the lethal triad. Okay, so the lethal triad is acidosis, hypothermia, and coagulopathy. So if you become injured, you're then shocked, you're not perfusing your tissues, you're bleeding, and you're exposed, okay? You're becoming cold, right? This all then leads to this sort of triad of death, which is, is what kind of well known in trauma circles, okay? You become acidotic, you become coagulopathic, you become hypothermic, and once you enter this sort of spiral, it's very, very difficult to get your patients out of it, okay? You've got to actively intervene to break that spiral, right? And that's the whole point of damage control surgery, damage control resuscitation. We're trying to address these three areas. So the first one we're going to talk about is permissive hypotension. And that's a strategy of restricting fluids until hemorrhage is controlled. Now, that to me is fairly sensible, but you've got to accept that, first of all, you're going to have suboptimal perfusion for a period of time. And what we're aiming for in this scenario is maintain enough blood pressure to perfuse the vital organs, i.e. the brain and the heart. So if there's enough blood pressure for the patient to continue talking to you, if they're able to, then that's enough. And usually it's around 90 millimeters of mercury or thereabouts, so palpable radial pulse. Okay, so that's where we're aiming for and no more. And again, like I mentioned before, I can still remember the days where, a ruptured aneurysm, for instance, you would have 2 or 3 people with loads of lines squeezing saline into the patient, trying to drive up the systolic pressure to whatever, and we wondered why these patients died, okay? And the other thing we've got to bear in mind is lots and lots of saline interferes with hemostasis. It dilutes out the blood volume, it dilutes out the clotting factors, the platelets and everything. So, again, you put too much saline in, you end up with very watery, non-clotting blood. And certainly in our patients in the Merseyside area, the most saline any trauma patient will get or should get is 500 mils. Okay, we restrict fluids a lot, and if you're going to give fluids, we give blood, okay, which moves us on to the next. So again, just going on that, prevents dilution of coagulopathy. Limited evidence, but it is adopted by the US and UK military, okay, and NICE and ATLS now. Excludes patients with significant head injury for obvious reasons. They're the ones you have to keep perfusion or drive perfusion. And you don't want to do it too long because it does have adverse effects, prolonged hypotension. Which then moves us on to the hemostatic resuscitation, which is basically stop the bleeding, okay. Hemorrhage is responsible for 40% of trauma deaths. Okay, people bleed to death. Okay, and if you develop coagulopathy, that is an independent predictor of death. Now, you will develop a coagulopathy just by being injured. Sometimes it's not the bleeding, it's the pure fact that you are injured. Okay, and this acute traumatic coagulopathy was really only first recognised back in, I guess, around 2007. Some of the work out of the units at the Royal London look in some of their data. And again, the development of coagulopathy, very difficult to predict who's going to develop what coagulopathic response, but it is a predictor of death. Okay, and again, we look for it and we deal with it actively with point of care testing here in Liverpool. So if you lose blood, give blood. That seems to me fairly sensible. Now, in the past, this is the kind of very traditional view, and this is still prevalent in areas where they're not dealing with major trauma, massive hemorrhage, where they will give crystalloid, then followed by some red cells, and every 6 or 8 bags of red cells, they'll give some clotting factors. This is a very old-fashioned view of things, and it does kill people. Okay, this shouldn't really happen in the context of, well, anything. In fact, there was a case in the news a month or 2 ago of a patient, an obstetric patient who bled to death. Probably is a direct consequence of this sort of level of resuscitation, and it's not a good thing to be looking at. Again, if this is the sort of thing that's happening in your units, you should be looking at the evidence for massive transfusion protocols and all the rest of it. So basically, this is one of the areas that the military have really come into research. A lot of this evidence has come from Afghanistan, where they looked at the outcomes were soldiers who were injured and what they were given and ratios of blood product. At the moment, the evidence base is around, best evidence is probably 1 unit of red cell, packed red cells to, 2 units of packed red cells to 1 unit of FFP. At the moment, as far as I'm aware, the US and UK military practice 1 unit of packed cells, 1 unit of FFP to 1 unit of platelets. So it's a 1-to-1-to-1 ratio. And the forward aid teams and the helicopter retrieval teams actually carry this on the helicopters within their vehicles. And in fact, we're starting, and again, this is happening all over throughout the United Kingdom now, is that the HEMS teams, the helicopter paramedic teams and the medical teams are carrying blood on the helicopter. So this is actually another transfer into civilian practice. And again, there's significant reduction in mortality. So the analysis down in 2007, again, US military casualties in Afghanistan, 46% reduction in mortality with a 1 to 1.4 ratio of packed red cell to FFP compared to the traditional 8 to 1. Okay. These advances in military trauma practice are being converted to civilian practice. Next area we have to address is hypothermia. Now, if you become injured and you're outside, you're on the floor, you're exposed, your core temperature will drop, and that is potentially quite dangerous. Below about 34 degrees, clotting does not work. Okay, you will not clot. You won't form. All the factors don't work. Enzymic functions impaired, and actually, if your core temperature in trauma is less than 32 degrees, you have 100% mortality. Now, you're injured, you get brought into hospital, and in the trauma bay, the first thing we do is we cut your clothes off. Again, exposing you, and so unless you've got sort of higher temperatures in trauma areas, or you're actively warming patients from the outset, you're going to get cold patients and you're going to cause problems for yourself. And again, prevention is easier than reversing it. So we try and limit exposure. We're using warm air devices, heating mats, and also all fluids, blood, everything is warm. It goes through a warmer. And even the Belmont infusers will go through a warmer to try and warm the blood we're giving. Okay. Again, hypothermia is important. It impairs the ability of the body to deal with bleeding, and ultimately, if you don't address it, it will kill patients. It's all, and again, all part of this triad of death. And then we come to what's actually a fairly small part of this, is the damage control surgery. Now, damage control surgery per se is split into several stages. Okay, first stage of the operation is very, very quick. Okay, the initial operation consists of three things. Okay, you control the bleeding, you control the contamination, and you close the abdomen. The end. No more. Okay, so it's very quick. You're aiming to get the patient on and off the table within about an hour. Okay, you do not want to do anything sort of technically clever or fancy. Right, stop the bleeding if necessary. Repair vessels quickly. Shunts, you know, very, very useful context of major vascular injury. Holes in the bowel, close them, and again, there's some methods to close the abdomen, which we'll go into. The next stage is then you park the patient in critical care, okay, and then you address the physiology, okay, hypothermia, the acidosis, and the coagulopathy. You warm the patient, okay? You address the coagulopathy, you address, you know, you give them clotting factors, transfusion, correct the acidosis, okay, and then the definitive surgery is delayed until the physiology is normalized. Now that will involve removal of packs if you've left them, dealing with any bowel injuries, any other injuries, and then looking for anything you've missed, okay? So you have three stages of damage control. You have the phase one, initial sort of control of sort of bleeding and contamination. Phase two, fix the physiology. Phase three, fix the patient. What we're trying to do is not this, so at the top here we have this kind of stepwise sort of pathway where we're in the trauma bays here, okay, we're trying to resuscitate the patient, and then we take the patient to theatre, and fix them there, and then we transfer them to critical care, okay. We're trying to come away from that into one continuum of resuscitation. Now this may mean that we take the patient to the operating theatre at the outset. Okay, we have a severely injured, smashed up patient who's unstable, bleeding from everywhere, and we don't hang around in the ED. We take them straight to theatre, and surgery and resuscitation is a simultaneous process. It's all part of the same thing, and that's where we should be aiming for our major trauma patients. Okay, it's sort of a unified, smooth pathway involving surgeons and anaesthetists. Now, we've got to select our patients for this. Now, overall, damage control, we're looking at about 10% of our major trauma patients, but no single factor predicts who needs it or who requires it. A lot of this is a judgment call. Okay, you should consider it when the magnitude of bleeding exceeds the patient's limits. Okay, and again, the sooner the decision is made, the better the patient, the better outcomes for the patient. Okay. The later you apply damage control principles, the less successful you are, because that means you're in trouble. Okay, and that means you have to bail out, you have to think, you have to abandon plan A, move to plan B, C, D. Okay, if you're thinking you're going to need damage control, and there's been several cases where I've just walked into a resus bay and go, right, the patient's going to theatre, and I'm going to do, I'm going to stop the bleeding, I'm going to stop any contamination, I'm getting out. I make the decision before I start the operation. And the sooner you do it, the better it is for the patient. Certainly we've pulled out, we've had a couple of patients with very good outcomes who came in was very, very ill indeed, just because we've started this from the outset. So things like significant bleeding, need for a massive transfusion, more than about 10 units, okay? Again, that's not that uncommon. Severe metabolic acidosis, so anything with an acidosis pH of about less than 7.3, 7.25, you really start thinking about damage control. Low temperatures, anything you think about, you're going to have to operate more than about an hour, hour and a half, okay? Any evidence of non-mechanical bleeding, right? Are they clotting? And high lactate. Again, if any of these factors or any combination of these, you should be really thinking of bailing out, okay, and employing a damage control strategy just to get the patient off, and then you can worry about everything later on once the physiology has been corrected. It's all driven by physiology. Okay, that's the thing that you had in first year as a medical student. You know, that you can vaguely remember. So damage control surgery, we went a bit over this a bit last week. So basically it's a rapid control of hemorrhage. So packing, we explore the abdomen, control any contamination, and then we may just put packs in and leave them. You know, we can leave them for a few days if necessary, and then we close the abdomen, and there's a few ways described to do that, and I'll go through a few things as part of this. So packing, again, we talked about this last week in the context of liver trauma. Basically, as you go in, trauma laparotomies, we do this thing called 4-quadrant packing, where you basically pack all 4 quadrants of the abdomen, especially around the liver. And again, if you've got liver, then the idea is to make it look like a liver, squeeze it all together and pack around it, hold it all together. Pack up by the spleen, if you've got that, will control a lot of splenic bleeding temporarily till you get control. You can take a spleen out very quickly if you need to. And again, if you're really running into trouble with distal bleeding, you can get a hand or a fist on the aorta as proximal control. But again, having to do that, you're in real trouble. Now again, like we said last week about liver packing, it's just a matter of putting the liver back together and just squeezing it and just keeping that degree of pressure on. Okay, and then you just take out packs one at a time. Start furthest away from where you think the big injuries are, and then you can identify the problems and deal with them as they come up. So like I say, we go around the abdomen. So what we're looking for are any active bleeding, retroperitoneal hematomas are a big one. You've got to think about what we do with those. Any bowel injuries. Again, you know, just basically you've got to run the abdomen top to bottom, identify injuries, and often deal with them as you find them, okay? And sometimes you have to run the bowel 2, 3, 4, 5 times, okay? The one that you've really got to be careful of, and certainly my experience, and we don't have many in Liverpool, but we get the few, is shotgun injuries, okay? Those pellets can get everywhere. You know, we had one case where we had 15 enterotomies to find, which was a fun few hours. And dealing with the bowel is relatively straightforward. Okay, so if there's some small holes, I mean, you see here we've got 3 holes, we've got some Babcocks on there. Okay, so just to control it while we're working. Again, we can use staple guns, linear staplers, you know, to resect segments of bowel. You can close small holes with skin staples. Or you can stitch them, okay? You've just got to close the hole in the bowel, okay, and stop any further contamination of the abdominal cavity. Again, very simple to do, very quick, very easy. Okay, so we've stopped the bleeding, we've then controlled the contamination, and then we're going to get out, okay? Now, the way to get out is you can do several things to close the abdomen, okay, to keep it closed. Now, a couple of these are largely historical and somewhat comical. Here we have virtually every towel clip, I think, is in this hospital. Again, these are from another presentation. Again, you can close the skin, staple the skin if you want, but just close the skin over the wound, leave the fascia alone. Okay. This middle one is something called a Bogota bag. Now, these are my personal opinions. If any of my patients has this done to them, I will hunt you down and we will not be talking afterwards, okay? This is not a good thing to do, in my opinion, okay? It wrecks the fascia. It's very difficult to control the fluid coming away from the wound, despite all these drains. The ITU teams will not thank you for it because the beds get very wet. There's huge fluid shifts and it really makes the bowel edematous underneath. Last one, which is my preferred method, is the various vac systems available. There's a couple of ways of doing this. There's the so-called off-site salmage, which is you can make there's a couple of commercial vac systems out there. You know, again, you know, we use something called Nabthera in Liverpool. You know, other commercial systems are available. But these are very good. They protect the fascia. They don't allow much retraction. And again, you can leave these about up to 5 to 7 days sometimes and still be able to close the abdomen. So close the abdomen, and then you put the patient on the intensive care unit. You allow the critical care guys to correct the physiology, and then you come back for definitive surgery, and it's all timed by the physiology. Okay, there's no particular time limit. Maybe 6 hours down the line, you get the call, yeah, the patient's fine, we've corrected the acidosis, the clotting's normal, and they've got a normal core temperature. It was perfectly reasonable to take the patient back then, and then you've got all the time in the world to perform definitive surgery. Okay, it may be several days. I think the longest I've left someone is 3 days, you know, with stapled ends of the bowels, open abdomen, and again, we're just correcting everything that needs to be corrected, and then when everything was right, we take the patient back, and then we can fix it. You can do primary anastomosis of bits of bowel, and it's a lot better for the patient if this is done. In fact, you know, certainly from the experience from Afghanistan, from the transfer of patients from Camp Bastion to the military hospital unit at the QA in Birmingham, you know, your time to, all they did in Bastion was damage control. You know, left the abdomens open, you know, temporary closure, and then moved, you know, shipped them halfway across the world in the back of a massive aeroplane, and then performed definitive surgery as and when the patient was better. Okay, and certainly the outcomes from, you know, the military in the Afghanistan campaign improved dramatically once those retrieval and those principles became established, and you know, they are becoming more established in civilian practice, which is where we come in. So actually, that's just a hop, skip, and a jump through basic principles. And I've kept it very basic because there's a lot of my colleagues who don't quite get this, who don't understand this, because it is relatively new. Okay, and you know, still thinking, you know, if you've got bits of hole in the bowel, you should try and do something definitive. Okay. But again, damage control as a concept requires simultaneous resuscitation and intervention. Okay, if you've lost blood, you give blood. I mean, that to me now is intuitive. Okay, you don't give lots and lots of saline. I don't, you know, just for volume. Okay, we've got no oxygen carrying capacity, so you're just diluting everything out, and you're making things worse quite a lot of the time. And also keep it simple, right? This is not rocket science, okay? This is a very simple principles. These are very old principles, as I illustrated before. You know, these ideas have been around for years, yet we're only just getting a handle of them, right? You control the bleeding, you control contamination, and no more, right? Again, the damage control mode, you do not have the time to be clever, and you want to be off the table in less than an hour. If you're having to do more than, you know, on the table for more than an hour to do stuff, in this sort of situation, you're going to run into trouble. Okay, definitive surgery can wait as long as it can wait. Okay, you don't have to rush in and fix things. Again, all driven by physiology. Okay, it's that basic. So hopefully I've given you a kind of an overview of damage control. Now it's mainly for trauma. Okay, I've come at it from the angle of trauma, but this is equally applicable to things like proliferative diverticular disease, for, you know, fecal peritonitis. You know, if you've got unstable patient from other, you know, ischemic bowel, that sort of thing, you know, you in similar idea, just resect what you have to do, get rid of the dead stuff, you know, bail out, close the abdomen somehow, come back, second look. Okay, all those principles are equally applicable across the spectrum of general surgery. So with that, I will take some questions.
Right. Okay. Sorry. Hello, John. Excellent talk. Thank you. So we've just got a couple of questions. One is, ATLS continues to support the use apparently of the 3-for-1 rule, but you've said 2-for-1.
Because they're 10 years behind.
That's what I thought was, but before I slagged off ATLS, probably they're out of date.
Yeah, the ATLS, this is a big thing within the trauma community. The ATLS are way behind on this one.
Yeah.
Only just got the hang of this. I think they're on the 10th edition of the course. This has only just made it into the manual.
Yeah, no, well, that was my thought. But before I sort of said bad things about ATLS, I thought I'd just check with you and make sure that it wasn't anything else. And then, what's your thoughts of the use of TXA in major bleeds and how it impacts on the triage of death? We've been asked.
It's interesting. I mean, if you look at everybody talks about the crash trials, and it's interesting difference in practice between the UK in particular. I mean, I know what the practice in this country, and certainly what the practice is in America. The Americans don't touch this with a barge pole in the large part. They just don't accept the evidence. Whereas we've been in the UK have been a bit more, well, it's probably going to do some good. So basically, any trauma patient now will get TXA in the field from the paramedics. Right? And that's certainly in Merseyside, and I think that's pretty much national at the moment. I don't think the evidence, again, is open to question. It's not solid, but there is, it's on the side of it probably does help with bleeding. Right? I don't think it really interferes per se, but again, the evidence is, you could argue either way.
Okay, good. And then finally, I think just one last question we've got. Have you any experience of using ECMO in trauma?
No.
What do you think about its use? I've never heard of it. I can't see a role myself.
No, I had a conversation. Funny enough, I had a conversation this morning. We had a case here last week where crush injury, where literally the right atrium was ripped off the cava, and the patient was GCS 14 until literally 10 seconds before the knife went in for the thoracotomy, and we couldn't control it, because and we said, well, would that outcome have been different if we could get a bypass, cardiac bypass? And I guess ECMOs is kind of within that kind of area of technology. In most trauma, certainly most trauma units in this country, and I suspect around the world, just don't have access to that level of technology and/or expertise. I suspect there's some of the big units in the States have have access to that level of expertise. I've never really heard of ECMO or within a trauma context, because you've got to be doing something quickly, and to get ECMO, it takes a bit of time. You need facilities, resources, and all the rest of it. Unless you've got one in the corner ready to go.
Yeah, no, I agree.
It's going to be difficult.
Okay, I think that's pretty much rounded off everything. I think it's been a very interesting session. May I just remind everybody about next week's webinar on head injury, and may, on everybody's behalf, I just thank John for an excellent talk.
Okay, thank you.
Okay, thank you. Brilliant. Thank you, John.
Okay.
Good afternoon, everybody, and welcome to this webinar today, supported by the Royal College of Surgeons in Edinburgh and the RSA, who we thank for the opportunity to present this. My name is Mark Bignell. I'm one of the consultant surgeons at the Oxford University Hospital, specialising in emergency and colorectal surgery. And it's my pleasure to present John Taylor, who is going to talk to us today about the principles of resuscitation and damage control in abdominal emergencies. As always, for those of you who are familiar with the format, we will have a Q&A session running whilst the presentation is going on. I will answer questions as we go, but if